Thank you. Thank you for the opportunity to be here and to present our data. I am Ettore Nicolini. I work in Sapienza University in Policlinico Umberto. And we right now have 1 year experience with CERCare. And so last year we had just some months experience, so now we are more used to it. And I will talk mainly about no-reflow phenomenon, and we show you that actually there is a lot of confusion. This is a spoiler. So first, we have to start from futile recanalization. So patient that we treat in the best way with good recanalization, TICI score to be free, and that do not reach the functional independence at 90 days. Consider that in trials, so in very selected patients, futile recanalization are about 30 to 60% of our patients, while in real-life study, half of patients experience futile recanalization. So, of course, futile recanalization depends on many things, frailty, age, but another possible explanation is the no-reflow phenomenon. This is actually an old concept, because we know it exists from late 60s. It was studied in animal studies, in rabbits and dog brains, and is defined as the absence of perfusion in the capillaries, parenchymal microvasculature, even if there is restoration of patency of the main artery. Actually, after that, neurologists just forgot about it, and cardiologists came in and did a lot of research on no-reflow phenomenon in heart. But after thrombectomy, we decided to get again on this topic. So from the latest publications, no-reflow phenomenon should exist in 1/3 of our stroke patients. And this is a complex phenomenon. We don't know actually from what it depends. It may depend on the vascular wall structure, so from edema of the endothelial cells, or from endovascular factors such as red blood cell and platelets entrapped in the capillary, causing occlusion, or maybe also from extravascular factors such as vasogenic edema or pericyte edema. So, but actually to date we don't know how to detect it in our patients. We tried to detect it in angiography just after the recanalization. We thought this was the best way. I mean, you recanalized, and then you can have images of 3 different phases: the arterial, the capillary one, the venous one. So we selected a population of patients with large vessel occlusion from the anterior circulation with successful recanalization, and created a new grading for no-reflow phenomenon, which we called modified capillary index score. Actually, we divided our MCA territory in 3 segments and gave a grading according to capillary phase. So if capillary phase was delayed, we gave 1 point, 2 points if it was not delayed, and 0 point if we could not see the capillary phase. what we saw was that there was an association between this definition of no-reflow phenomenon and failure of any early neurological improvement at 24 hours and at 7 days, as well as hemorrhagic transformation. But still, there are some limitation of this kind of evaluation, because we are just looking at MCA. We cannot compare to the rest of the brain. So maybe the perfusion imaging could be the answer to detect the no-reflow phenomenon. Different studies in the late 5 years have tried to detect it in our patients. So the first study was a French study using MRI arterial spin labeling, and defined no-reflow phenomenon as more than 40% reduction in CBF on 24-hour MRI. What they found was that just one patient presented no-reflow phenomenon. So the conclusion was maybe no-reflow phenomenon in human is not so frequent. Later on, there was a study from a post-hoc analysis of the EXTEND-IA, where they defined the no-reflow phenomenon on 24-hour perfusion imaging, MRI or CTP, as a interside asymmetry more than 50% of relative cerebral blood volume or cerebral blood flow. In this case, no-reflow phenomenon was found in 25% of patients, and they found that it predicted functional outcome and early neurological improvement, as well as hemorrhagic transformation. Actually, just today, another paper from this group was published with the data also from the EXTEND-IA TNK, and they found that 1/3 of patients at this definition of no-reflow phenomenon. I didn't add it to my presentation also because I care about Aurelia mental health, so I didn't want to change at last my presentation. But still, this definition of no-reflow phenomenon has some limitation. We know that no-reflow phenomenon should be, as for animal study, mottled. So maybe this macro evaluation, hemodynamic evaluation, cannot see little spots of no-reflow phenomenon. And then, of course, there are pre-existing conditions such as carotid artery stenosis and chronic lesion that may impair the perfusion imaging. Later on, we have data from the CHOICE trial. We know that the CHOICE trial showed that intra-arterial thrombolysis improves the functional outcome after a successful recanalization. In a sub-study of the CHOICE trial, just 40 patients, they wanted to look if this intra-arterial thrombolysis had some effect on the no-reflow phenomenon. They define no-reflow phenomenon as an area of hypoperfusion within the infarct core in the 24-hour imaging. Actually, they found that patients with intra-arterial arteplase did not experience no-reflow phenomenon, while the others actually experienced hypoperfusion within the infarct core. Finally, this is a study from a Swiss group, from the Bern group, which tried to define different patterns of perfusion within the infarct core at 24 hours. So they selected LVO patient treated with mechanical thrombectomy and a TK score 3, and they excluded patients with hemorrhagic transformation, tandem lesion, or reocclusion. And then they classified the patients according to the perfusion imaging within the infarct core. You can see that they evaluated the cerebral blood flow and cerebral blood volume. This is a qualitative assessment. So they found that most of patients had normal perfusion within the infarct core. Then there was a group of patients with hyperperfusion, a little group of patients, just 17 patients with hypoperfusion, which should be the no-reflow phenomenon, and 50 patients with a mixed perfusion group. So first, we can see that we have just 5% of patients with no-reflow phenomenon. Before, we saw that some study said there is 25% of no-reflow phenomenon, others just 1 out of 33. And what they found was anyway that perfusion within the infarct core after 24 hours predicted the functional outcome, both 90-day functional outcome and early functional outcome, so improvement at the NIHSS score. In particular, the hypoperfusion, so the no-reflow, even if it was rare, it was associated with worse outcome and lower chances of functional independence. So, starting from this, then, just to remind, I present the study from Professor Ostergaard about capillary transit time. When we read it, we just thought, oh, this is the answer. We want to look at no-reflow, we want to look at capillaries, and actually the concept of capillary transit time heterogeneity fit perfectly to no-reflow phenomenon. And also the study from the preconditioning Horus study showed through this model that in ischemic stroke there are 3 different phases according to CTH and RTH. RTH is a sort of coefficient of capillary transit time heterogeneity. So it's a ratio between CTH and MTT. We need this RTH because, of course, CTH is dependent on MTT. So what they found was that there is a first phase where both CTH and RTH increase. This is the phase of reduced perfusion pressure. Then there is a phase of capillary constriction, where we see still increase of RTH and CTH. And finally, we have the first phase, the phase of capillary occlusion, in which there is a decrease of capillary transit time heterogeneity. So, starting from this, we decided to analyze CTH and capillary transit time heterogeneity on our patient. In our hospital, we do systematically perfusion imaging in acute phase, and as well as at 24-hour we perform MRI with perfusion imaging if the patient has no contraindication. So we selected patients with anterior circulation large vessel occlusion from 2020 until December 2024, treated with mechanical thrombectomy with successful recanalization. From 374 patients, we had perfusion imaging at 24 hours from 196 patients. 61 patients were considered as having suboptimal perfusion imaging. We excluded patients with hemorrhagic transformation type PH1 and PH2 for the ECAS2 classification, as this might have impaired the perfusion imaging. We, of course, excluded patients with reocclusion after the procedure. So in the end, we had a cohort of 112 patients to be analyzed with perfusion imaging. How was our definition of perfusion imaging? So first I have to thank Mikkel for helping us having this kind of definition. We defined the infarct core, the infarct volume, infarct areas with the apparent diffusion coefficient below 620. And we defined also a mirror area in the contralateral hemisphere. Within this true area, we analyzed the perfusion parameters. Here you have two examples of patients. The first one has a reduced capillary transit time heterogeneity within the infarct lesion. The second one has an increased capillary transit time heterogeneity within the infarct lesion. So these are all the different parameters we evaluated. So these are the descriptive data of our population. As you can see, of course, the predictors of functional outcome were the infarct volume, as well as the combined treatment, so intravenous thrombolysis plus mechanical thrombectomy, which might actually act on also no-reflow phenomenon, as well as, of course, the severity of stroke, so baseline NIHSS and age. So as for the perfusion parameters, we found a difference for functional outcome for the CTH and a trend for RTH. Let me show you. We also defined the no-reflow phenomenon with the definition of the extendia TNK, so an asymmetry more than 50%, but we found actually no difference, or actually a trend for worse outcome, a better outcome in patients with no-reflow phenomenon. So this is the graphical representation of what we found for CTH. Patient with worse outcome, so with a modified Rankin scale 3, 6, and 90 days, or 2, 6, and 90 days, at lower mean values of relative capillary transit time heterogeneity. Then we tested this finding in a multivariate regression model, and we adjusted also for MTT, given the dependence between MTT and CTH, age, sex, severity of stroke, final MTC score, as well as the infarct volume. We found that there was an association between CTH and functional outcome, both worse functional outcome defined as a modified Rankin scale 3, 6, and 90 days, and the ordinal shift analysis, as well as with a modified Rankin scale 2, 6, so the inverse of an excellent functional outcome. So we found actually that lower capillary transit time heterogeneity was associated with futile recanalization after successful recanalization. These results are in line with the study from Eggendal. Actually, what we found, this lower capillary transit time heterogeneity, should be the third phase, the capillary occlusion, the no-flow. Indeed, CTH, relative CTH reduction might be a marker of no-reflow phenomenon. Of course, we still need to explore the characteristic of the patient which were excluded because of suboptimal perfusion imaging. And in the future, we need to do a prospective core study, and we need to compare our definition of no-reflow phenomenon with our other methods, with DCA, with transcranial Doppler, and our method should be validated in an external court. So, recanalization is necessary after LVO, but is not sufficient, and we need an imaging marker of no-reflow phenomenon, and we don't have it at present. Actually, perfusion imaging might give us some data on no-reflow phenomenon, but we have conflicted data. You see some studies saying that just 6% of patients have no-reflow phenomenon, other 30, other 25. Capillary transit time heterogeneity might represent a good method to detect capillary obstruction after successful recanalization and then no-reflow phenomenon. Thank you.
Thank you so much for sharing these exciting data. Are there questions?
Building on the talk of the colleague previously, the thing that interests me the most as an interventionalist, also based on the choice trial that you have mentioned, what did you do with the patients that had hemorrhages? Because that would interest me. Like, okay, I have a no-reflow phenomenon. Mm-hmm. According to choice, I could say, okay, let me give IV lysis right now, or EIA lysis. But if I already know, based on the things that you have shown, that I'm going to bleed, I won't do this. I want to treat only the patients with the addition of lysis intraarterially that I know that are not going to bleed. Like, did you look into those patients also, like the parameters that predict a hemorrhage?
Actually not, because we excluded patients with hemorrhage, because for a perfusion study to have this is the first definition of no-reflow phenomenon with CTH, so we needed the real clean data, so we excluded that. But we know from our study on DSA that actually no-reflow phenomenon, so a delay in capillary phase predicts hemorrhagic transformation, as well as in the study from Extend IA, they found that reduced CBF and CBV could predict hemorrhagic transformation. So thinking about what was presented before, ideally, we should detect no-reflow phenomenon just after recanalization. So if we could use, for instance, combined CT, this will be ideal. In retrospective data, we have, of course, just 24-hour imaging, but ideally, doing it just after recanalization will be perfect, so we could choose to give intraarterial thrombolysis, actually. So these are the data we have.
Yeah, thank you for answering this question. So based on this, because I'm doing like this on a monorail design, no reflow, is it only due to microemboli, or is it due to something else? Because if it's up to something else, we talked about it yesterday, I think, about giving nimodipine in these patients, like, can we really detect the reason for no reflow?
Yes, so according to this data that I presented, I would say that is occlusion. So it's what was found first in animals. So red blood cells and platelet entrapped, which occlude capillaries. But actually, other study found that it was constriction, as you said. Maybe my thinking is that we cannot know it until we just see 24-hour imaging. Maybe if we will find using the combined CT or doing like earlier post-recanalization perfusion, we could find that CTH is increased. In that case, I will think that it is constriction rather than occlusion. So it should be the second phase from the study from Egendal. But with this data, I would say it is occlusion, so we need some lytics or something like that to add on no-reflow phenomenon.
Other questions? Yes.
Hi, thank you. Quite interesting data, actually. My question is, the whole thing is very dynamic, and you're taking a single snapshot and trying to interpret the whole dynamic things, which has got lots of other physiological parameters like, how the blood pressure is fluctuating and other thing, etc. So is it actually an oversimplification of what is happening out there, trying to interpret something which can be completely different? So one of the way to look at it is that in your data, the people who actually has no reflow phenomena, but had a MRS 0 to 1 or 0 to 2, what is the difference between that group and the people who had no reflow, who didn't have a MRS 0 to 2 or 0 to 1? So did you do that kind of analysis to show that there is a difference between the group as well? Because I mean, to me, it looks like more simplified data than what you're trying to do with physiological changes.
Yeah, I see your point. Actually, we did not show a definition of no-reflow phenomenon. The simplification you are talking about might be applied to the other study I presented, where there was a cutoff definition, patient with no-reflow, patient without no-reflow phenomenon. What we found was a dynamic relation, actually, between CTH and functional outcome. So I believe that is not like so cut off, so dichotomic, no reflow and yes or no. It could be dynamic. And on the other end, I think that a modifier Rankine scale is not the better outcome to measure no reflow phenomenon, but is the best outcome we have right now. Maybe lesion volume could be another outcome, or failure of early neurological improvement could be another outcome. Because of course 90-day modifier Rankine scale is different because of frailty and a lot. Anyway, our multivariate analysis had a lot was adjusted for many of different parameters that were found to influence 90-day modifier Rankine scale. And my message is that there is an association between CTH, between capillary state and functional outcome. Then, if there is a cutoff classification of patient with and without no-reflow phenomenon, this I cannot say with our data.
Thank you so much. Thank you for sharing these exciting data. Let's give Ettore a hand.